So I'm the head of breast imaging. So it's a very close topic to me because it's my specialty. As you said, it's very saddening to keep hearing the number that, it was the most common cancer in females, and now it's become the most common cancer all over. So it is the most common cancer. And it's a constant fight. We are fighting, trying to get that number down. And especially at least try to catch the cancer as small as possible so that we can help the patient early and she has a better outcome. So, the later they come, the treatment options are limited and the survival rate gets affected. So it's trying to catch that small little cancer where screening comes in.
Excellent. And then when we speak about screening, for years and years, we speak about mammography. Yeah. And then today, I want to ask you, is there any update with mammography? What's the place that artificial intelligence is playing with mammography?
All right. So first we started with 2D pictures of the breast. As we know, it was just a conventional mammogram, so the pictures were fuzzy. The quality kept improving. We went to digital mammography, which made it much easier to look through the breast tissue. Then came tomosynthesis, which in layman language is known as 3D mammography, which also improved our accuracy of picking up a finding or as small as possible. Then came in the most rudimentary form of AI, which was CAD, computer-aided detection. So actually, breast imaging was the first one to adopt that rudimentary AI product. It was launched in 1998 and started being implemented from 2000 onwards in all clinical practice. Now it has advanced to deep learning, which is AI, the newest form of AI. So that implementation has really helped. It has several steps of how it's helping breast imaging, in particular mammography, is that first, it can read the image and it can highlight the findings for you. So the way I would explain that, think of AI as a super efficient assistant who's sitting right beside you and is pointing at a particular point in the image and saying, please look here. This looks a little abnormal. So it draws our attention to a particular side. And in tomosynthesis, what happens is that we actually do slices through the breast, as we call it. It's like a mini CT scan of the breast. So we have about 150, 160 images of each breast with each view. So the system, the AI works and tells you which slice to stop at and have a second look at a particular area. It's also brilliant at triaging. So for example, if I'm starting a screening mammogram or any breast radiologist is sitting on a list to read screening mammograms and has about 100 mammograms she needs to read right now, it triages, so it highlights the ones which have findings and it brings it up on the list so that it says, pay attention to these ones first because I think there is a finding on it. So you pay attention to the potential cases which may need more attention. And then you go to the cases which have been deemed by AI to be normal or within normal range. So it helps to become more efficient and more, focused on picking up those cases which need to be recalled early. So that's how it helps.
This is fantastic. I mean that it's optimizing really the screening, in fact, from AI. What about the high risk, in fact, ladies? How AI and mammography is supporting also the early detection with them, especially?
So for high-risk patients, it does help because we are also using the AI solutions for defining the breast density. So as we know that more dense the breast is, the more likely of missing small findings. So if the patient is already towards the higher risk spectrum and she has dense breasts, which means category C or D, as you would see on the reports, that means that flags it to us that this is a dense breast and we need to work it up more. So if it's a category D, we may call the patient back and do an ultrasound to make sure there is nothing. If she has a higher risk history, what we would do is we would automatically refer it to our high-risk clinic, which we are fortunate to have at Cleveland Clinic. So we have specialized physicians, which are medical breast specialists, sitting there. They take over the case. They work up the case. If genetic testing needs to be done, a genetic counselor is there, so he talks to the patient. Genetic testing is done. So they basically work up the patient and then send it back to us that, yes, this meets the high-risk criteria, or this patient is within the normal range. So, treat her like a normal patient. Now, your question would be then, what do we do with the high-risk patient? So if you follow the guidelines, if the patient has been labeled to be at high risk for breast cancer, we need to be doing MRI scans and we need to be doing mammograms. And if it's a really like BRCA1 or 2, P53, certain gene types, we put them at a very high risk. So what we do is we stagger the examination 6 months apart. So we do a mammogram 6 months and then 6 months an MRI breast. So that's how we basically screen our breast patients which are at high risk. Now, coming to the next part of the topic. So what is fast MRI scan? So what happened was an MRI breast takes, roughly speaking, about 40 minutes to do the scan. It's an uncomfortable position because the patient is lying on the stomach for all that time, and they move, and you get movement artifacts. They don't like it, and what happens is that you lose that population. They will not come back to you next year. So then it was looked into how can we make this better for them. So hence came fast MRI scan, which technically means abbreviated MRI scan. So we do lesser sequences, but we do the most required sequences to catch that more invasive kind of cancer a patient might be hiding. So that is done like the system, the protocol we are using at Cleveland Clinic. We've shortened it to 12 minutes, and we're hoping to further shorten it to maybe about 9 minutes. So it becomes very comfortable. We launched it in January last year, and our feedback from the patients has been great. So we're hoping that, the return patient population will keep increasing rather than decreasing. So that's what the fast MRI scan is. The idea is to find the more aggressive cancer and work up the patient.
Well, looks like it's more accurate, but also you look for the comfort of the patient. It's more comfortable for the patient. And then your patient is more compliant, in fact. That's really, in fact, interesting. But to implement all this new technology, and especially in Cleveland Clinic Abu Dhabi, I'm sure you went through challenges, and with all innovation. How did you face these challenges, especially in Cleveland Clinic?
So part of the problem is that fast MRI scan, the MR scan is an expensive examination. Any MR scan is an expensive examination. And fast MRI scans is actually not approved by insurance companies. But these are high-risk patients, and they are willing to pay for it. So now we're doing a short form of the MRI scan. So we had to work in the background, and we have an amazing team from the institute chair to our department manager, the finance team. Everybody worked on it and eventually got it approved that we are going to charge a very fractional price of a full MRI scan for the patient. And our patients so far seem to be happy to pay that amount in cash on the spot and get it done. It's literally like 1/4 the price of what an MR would cost you. And the credit goes to the entire team who really worked hard to bring the price down.
I think that the insurance are our partner. It means by proving to them the outcomes, especially on a screening level, we will be happy to discuss again and again. For most probably very soon it will not be a challenge. But I'm happy that you are sharing that also with the team, that despite this challenge, because of the effectiveness, in fact, of the test, you've taken the decision to have it, in fact, and to offer it to your patient. That's really a fantastic way of doing it. After our 3 questions, let me ask our audience. I'm sure they have some questions. Please. Can you introduce yourself?
Hello, my name is Alexei. I'm a scientist in the field of MRI. So my question is, if you are talking about the bottleneck, you said like 2.4 million diagnosed from one point of view. From another point of view, the dense breast, that is approximately 50% of patients. So, and dense breast cannot go directly to the mammogram because you will miss the problem. So I try to understand, is the bottleneck is the number of doctors, and when we can use AI to help, is the bottleneck is the price of one scan of MRI, is the bottleneck of number of MRI machine? That is interesting question. What is your vision here?
Thank you for the question. Dr. Naghma?
Thank you. That's a brilliant question. And to answer it, it depends which region we are living in and how we're addressing it. So for our side, our bottleneck would be more to do with having technicians, right? So ultrasounds. So if we recall more and more of dense breasts, we need to do ultrasounds on them. So either the radiologists are doing at some places themselves, or you have breast ultrasonographers who are doing it. And across the globe, there is extreme shortage of breast ultrasonographers, because these are highly specialized people. And it's very hard to even find them in the Western world, let alone them to come to us. So that would be one bottleneck. For what we are doing from our end, from that side, is that we are training some of our own general ultrasonographers in-house, who have shown interest in breast, and we've been really good at it. That they've shown interest, we take them in, we train them ourselves, and then it's on-job training, and then they get up to par, and then we can keep using them. So that's one part we're doing. Going to the second part of the MR scanner time. So far, we've been very lucky. We're in a very fortunate part of the world where we don't have to fight for the MR time that much, but it will come. As the numbers will go up, it will come. So then you will have to request for MR scans and more scanners, maybe dedicated MR scanners only for breast imaging. To counteract that, something which is also happening simultaneously is the contrast-enhanced mammography, which is a cheaper option. It is quick, and it can be done in the mammo suite, so hence you're not taking the magnet time. So that's another thing which the studies are being done on, and we're waiting for it to, unless it becomes guideline, you can't apply it to the screening population, but you can apply it on diagnostic side. So if you're recalling a patient, then you can apply contrast-enhanced mammography and take it from there. So that's another form of imaging we can offer if we run out of the MR scanning time.
Thank you so much, Dr. Naghma. Additional question?
Thank you very much. I am Azam Kayase from Dubai. I am gastroenterologist and a clinical microbiologist. Now let us go to part. The first part, screening. You mentioned about genetic. We cannot start to do microbiomic testing for this one. Why? To give you a proper patients for after treatment, we can do also microbiome testing.
That would be something I'm sure the oncologists would love to collaborate with you. From our side, we just hand them over to the Iris Clinic. And what guidelines they're following right now, I suppose the American guidelines, is that they do genetic testing. But I'm sure it will keep changing, and it will keep modifying, and they will keep including more and more tests in it.
Thank you.
Just to answer to you, this is included also in the panel, and we are lucky today to have you on board, and also to have Dr. Naghma, because one of the next session will be about microbiome and M42, and then some of our experts will be happy to discuss with you that. But we take the boats, it's in. Thank you for attracting the attention to the microbiome all the time, really. Thanks a lot. Additional question, please? Then, Dr. Naghma, we spoke about the challenges. You spoke about how Cleveland Clinic is implementing and implemented, but also I know that within Cleveland Clinic Abu Dhabi, you care about innovation, but also research. What are the next, in fact, and the future from an innovation part on breast radiology?
So We are looking into doing research related to breast in cooperation with the Oncology Institute, which would be Stephen and the entire team, actually, the oncologists, and they're wonderful people and very accomplished people. But from innovation point, our next step is we just got the contrast enhanced mammography software installed. We're hoping that we will also get the contrast enhanced mammography biopsy system with it. So that we can work up the patient from start to scratch. One of the beauties of contrast-enhanced mammography is also in that tiny percentage of patients who are claustrophobic, and we can't do an MR scan on them. So even if they're not high risk, if it's a breast cancer which we've diagnosed already on biopsy, now we want to see multifocal disease or contralateral breast involvement, we're stuck because this patient is either claustrophobic or unfit to get into an MRI scanner. So that would be lovely to start that, because those tiny percent we will, be able to offer them something. So that's what we are looking forward to. What is next innovation-wise coming to us? We are also working on getting, as you know, the coding and the orders and everything needs to be put in. So we are looking forward to starting vacuum-assisted excision of small lesions, small benign lesions, which we can go after. Like, for example, small papillomas. Instead of surgery, we can offer the patient excision without any general anesthesia, under local, with a vacuum-assisted biopsy system. We're also going to explore cryoablation. So that's another thing which we would like to expand into in breast lesions, cryoablation, which is really the hot topic right now internationally. So we are also looking into all of these new innovations and how we can bring them on board in CCAD, Cleveland Clinic Abu Dhabi, to just increase the spectrum of services we offer.
This is fantastic. Thank you so much, Dr. Naghma. And again, thank you so much for sharing the multidisciplinary approach for Fatima bint Mubarak Oncology, in fact, Institute in Cleveland Clinic Abu Dhabi. That's great to see all of you working on it. Let's have a call to action to all the people who are here, but also people who are hearing us, that women breast cancer is still very high, that screening is the key, that Emirates of Abu Dhabi is having a fantastic screening program called FHAS, that it's available everywhere. And when we hear your question, and when we are in this part of the world, okay, it's a crime not to go and do mammography and not to go and be screened. And then you have a team who is here, who is looking for innovation, who is looking for next, who is trying to fight with insurance. For each one of you, this is also the goal of this year, as per Sheikh Mohammed bin Zayed, that this is the year of community. Try to enhance awareness, try to enhance education, and be on board to fight together the breast cancer. Please, Dr. Naghma, the last words is...
I would just encourage everyone, please, any of your loved ones, anybody who meets the age criteria of 40 onwards, please encourage them, please tell them to go and get screened. It's better to find that small cancer before it becomes palpable. That's what the screening is all about.
Thank you so much, Dr. Naghma. It was a pleasure to have you on board.
Same
Thank
here.
you, everyone.
Thank you. Thank you very much.